Thank you, Dr. Richard Cacho, for the kind introduction. Thank you, SGOP and its organizing committee for this invitation. I consider it an honor and privilege. I am being given 25 minutes to lecture on management algorithm for women with breast complaints. I was given these learning objectives by the organizing committee, and I will give my lecture based on this outline and straight to the point. Most common breast complaints, initial workup, evaluation for its complaint, factors that raise suspicion for malignancy, indications for referral to a breast specialist. I'd like to disclose that I made an online survey among 34 OB/GYN respondents from March 2020 to April 2020, guided by the above learning objectives. I will insert the results of the survey into my lecture. Learning objective 1, most common breast complaints among women. To answer this question, as I said earlier, I made a survey from 34 OB/GYN respondents and also 31 general surgeon respondents this year. The unanimous answers, the most common concerns in the order of decreasing frequency: breast mass, most common; breast pain; breast check or checkup because of concern for breast cancer; and nipple discharge, least common. Learning objective 2, initial workup, evaluation for its complaint, history, physical examination, and diagnostic modalities. First principle to follow in the initial evaluation: regardless of the complaint or concern of the patient on her breast, whether breast mass, breast pain, breast check, or nipple discharge, a physical examination should be done before any laboratory diagnostic procedures. The physical diagnosis will dictate the subsequent moves in the management. Foremost in the physical examination is to look for a dominant mass. The real mass, the mass which is considered as the red flag, meaning if present, it needs at least more investigation. One should distinguish a dominant mass from the prominent and smooth or lumpy breast tissues, which are usually part of fibrocystic changes, which is considered normal and does not require surgical treatment. Here is the clinical diagnostic algorithm in patients with no dominant breast mass. No dominant breast mass found on physical examination in patients complaining of breast mass and in patients coming for a breast check. Your clinical diagnosis should be normal or fibrocystic changes. Breast pain with no dominant breast mass, your clinical diagnosis should be fibrocystic changes. Non-sanguineous nipple discharge with no dominant breast mass, your clinical diagnosis should be fibrocystic changes. Sanguineous nipple discharge with no dominant breast mass, your clinical diagnosis should be intraductal papilloma. Focal erythema and tenderness with no dominant breast mass, your clinical diagnosis should be mastitis. Here is the clinical diagnostic algorithm for those with a dominant breast mass. First, look for signs of inflammation. If present, breast abscess should be the diagnosis. If no signs of inflammation, differential now is malignant versus non-malignant. First, look for signs of malignancy. If present, malignancy should be the diagnosis. If no signs of malignancy, more likely non-malignant and a benign disorder should be the diagnosis, more so if there are signs of benignity. To amplify and illustrate the use of the algorithm, look for signs of inflammation and infection, such as pus, erythema, tenderness, and fluctuancy of mass. If present, primary diagnosis is inflammatory or infectious mass, or specifically abscess of the breast. If no signs of inflammation and infections are present, decide whether malignant or benign neoplastic growth. Then look for signs of malignancy, such as signs of local invasion, which include ill-defined border of the mass, fixation, retraction, ulceration, and fungation, and also look for signs of spread, axillary lymph nodes. If present, suspect malignant mass. If no signs of malignancy are present, more likely it's a benign mass, especially if the mass is cystic, meaning it contains fluid. So here again, the clinical diagnostic algorithm for those with a dominant breast mass. Very simple, very helpful, and very practical in coming out with a rational clinical diagnosis. Here is the clinical diagnostic algorithm for those with nipple discharge. Start with determining whether the nipple discharge is sanguineous or non-sanguineous, which can be watery, whitish, yellowish, brownish, and grayish in color. Non-sanguineous with no dominant mass, your clinical diagnosis should be fibrocystic changes. With a dominant mass in the presence of a non-sanguineous nipple discharge, evaluate using the clinical algorithm for breast mass that I have given above. Sanguineous with no dominant mass, your clinical diagnosis should be intraductal papilloma. With a dominant mass in the presence of a sanguineous nipple discharge, breast cancer until proven otherwise. Here is the algorithm for the laboratory diagnostic procedure. The general indications are: 1, if you need to be more certain after an uncertain clinical diagnosis derived from history and physical examination. So you're not certain about your clinical diagnosis. As a rule, if one is quite certain of the clinical diagnosis, as high as 90% degree of certainty, there is no need for laboratory diagnostic procedure. Second general indication, if you need to be more certain to increase the degree of certainty up to 98-99% on the clinical diagnosis, because the definitive treatment would be extensive and mutilating, such as total mastectomy, chemotherapy, and radiotherapy. The specific indications consist of the following. If there is an uncertainty whether a dominant mass is present or not, request for ultrasound. If there is an uncertainty whether the dominant mass is malignant or benign, request for an ultrasound. Request for mammography only in patients 40 years old and older who came for a breast check and there is no palpable dominant mass, and the patients are very anxious of possible malignancy because of positive family history. A common question being asked, which one is better if you have to choose one, ultrasound or mammography? I answered this question in 2012 to 2013 by collecting on a consecutive basis ultrasound and mammography reports. I was able to compile 54 ultrasound reports and 45 mammography reports and compared the BI-RADS categorization. BI-RADS stands for Breast Imaging Reporting and Data System. It is currently the standard system of describing breast imaging findings and results. It has 6 categories, namely BI-RADS 0, incomplete, needs additional test; BI-RADS 1, negative; 2, benign findings; 3, probably benign; 4, suspicious for malignancy; 5, highly suspicious for malignancy; and 6, with known biopsy with proven malignancy. Findings of my personal series show the following. Of the 41 ultrasound reports with BI-RADS categorization, no radiologist gave a BI-RADS 0 assessment. All, 100%, had a committed categorization from BI-RADS 1 to 6. Of the 45 mammography reports with BI-RADS categorization, 33 or 73% gave a BI-RADS 0 assessment. Only 12 or 27% had a committed categorization from BI-RADS 1 to 6. Thus, for a more definitive report from the radiologist, if one is given only one imaging modality to request, ultrasound is the better option. I have shared with you the clinical diagnostic algorithm for patients with no dominant mass, with a dominant mass, and with nipple discharge. I have also shared with you the algorithm for laboratory diagnostic procedure. Aside from the diagnostic algorithms, I'd like to recommend mammopathology and pattern recognition to enhance your clinical eye. It would be extremely helpful for all OBGYN to remember the names of just 10 breast disorders being encountered in the Philippines and know how to recognize them using pattern recognition. This will help them decide what to do next after the physical examination and history taking, or after the clinical diagnosis is obtained. Whether to refer to a breast specialist right away, whether to treat the patients right away when a surgical breast condition is not present, and to allay the fear of patients when indicated. These 10 breast disorders are the following: breast cancer, fibroadenoma, macrocyst, galactosile, mastitis and breast abscess, intraductal papilloma, phylloides tumor or benign cystosarcoma phylloides, tuberculosis of the breast, Paget's disease of the nipple, mammomegaly or virginal hypertrophy. I'd like to expound on some of them in the next few slides for pattern recognition purposes. Solid breast mass, well-defined border, very movable. This is the most common pattern for fibroadenoma. Cystic breast mass with no history of lactation. This is a common pattern for macrocyst. Cystic breast mass with history of lactation. This is a common pattern for galactosile. Huge breast mass, multinodular, with solid and cystic areas, with no axillary node despite the hugeness of the mass. This is a common pattern for phylloides tumor. Multiple draining sinuses with history of repeated bouts of breast abscesses. This is a common pattern for tuberculosis of the breast. Unilateral erosion in the nipple areolar complex, pattern for Paget's disease, a special type of breast cancer. Huge breast with no dominant mass, pattern for mammomegaly or the so-called virginal hypertrophy. Let's now go to learning objective 3, factors that raise suspicion for malignancy. The foremost factor is the physical examination findings on the breast. 1. The presence of a dominant breast mass with telltale or giveaway signs of malignancy, namely signs of local invasion of the breast mass on the adjacent tissues, and signs of spread, should raise suspicion for malignancy. Second, the presence of a sanguineous nipple discharge with an accompanying dominant mass should also raise suspicion for malignancy. Signs of local invasion of the breast mass on the adjacent tissues consist of fixation to the adjacent tissue, such as the overlying skin, inclusive of the nipple areolar complex, and the underlying tissue, such as the chest muscles and the ribs. The skin changes over the mass that are suggestive and indicative of local invasion, such as ulcerations and fungation. Signs of spread consist of the presence of palpable ipsilateral axillary lymph nodes and or supraclavicular lymph node. The degree for suspicion for breast cancer in the presence of local invasion alone without signs of spread will be at least 90%. The degree of suspicion in the presence of local invasion and spread at the same time will be moving towards the 99% probability. If there are telltale signs of malignancy, there is also one telltale sign of benignity of a palpable breast mass, which is the cystic nature of the mass on palpation. A breast mass, if cystic, meaning most likely the mass is fluid-filled, is probably benign. The probability is about 90% to 99%. Notes on the use of age and family history in the clinical diagnosis of breast mass. And the survey, when asked, in your practice, do you suspect breast cancer purely on the basis of age, say more than 40 years old? 20% answered yes. In your practice, do you suspect breast cancer purely on the basis of the presence of a family history of breast cancer? 43% answered yes. My recommendation, rely on the physical examination findings rather than on the age and family history in processing the clinical data for diagnosis for the following reason. The clinical diagnosis of breast mass with benign characteristics, such as in the presence of well-defined border and cystic nature of the mass, should be benign even if the patient is 40 years old and above, and even if the patient has a family history of breast cancer. Likewise, the clinical diagnosis of the breast mass with telltale signs of malignancy, such as signs of local invasion and signs of spread, should be malignant even if the patient is less than 40 years old and younger, and even if the patient has no family history of breast cancer. Let's now go to the last learning objective, indications for referral to a breast specialist. From the survey, all OBGYNs consider the surgeons, the general surgeons at least, surgical oncologists at most, as the breast specialists in the Philippines. The OBGYN knows that breast is part of the residency training program of general surgery, at least about 9 months of rotation in the management of breast patients. Majority of breast disorders are surgical disorders. The medical oncologists, ROJoson oncologists, etc., are considered adjunct breast specialists, meaning referral to them is done by the surgeons when indicated. So if one considers the surgeons as the breast specialist, all patients with a breast concern should be referred to the surgeons, unless the OBGYNs can do the management themselves or would refer to non-surgeon breast specialists as they think indicated. But at the very least, the following patient should be referred to the breast surgeon specialist. Patient who will most likely need surgery of whatever type, patient needing biopsy procedure, patient needing incision and drainage procedure, and patients needing excision and mastectomy. To end my talk, let me flash again to you the learning objectives assigned to me and to which I tried my very best to answer straight to the point within the time limit allotted to me. Most common breast complaints, initial workup and evaluation for each complaint, factors that raise the suspicion for malignancy, indications for referral to a breast specialist. I hope I have shared simple yet useful and practical tips to all of you, my beloved OBGYN, on the management algorithm of Filipino patients with a breast concern. Thank you for your kind attention.